My own view is an epidemiologic one. We have some very large-scale studies now completed which show that among individuals who exercise regularly, who diet, who do not gain weight in midlife, who avoid cigarette consumption, have extremely low rates of heart attacks and strokes. The problem is less than 4% of the United States currently fits those categories. So we have a tremendous need for education about preventive therapies, and we have a tremendous underutilization of those therapies, such as aspirin, such as the statins, that we already know are very effective in reducing vascular risk. It's now clear from major epidemiologic studies that more than half of all future heart attacks and strokes do not have high cholesterol levels. We've just completed a very large study in our women's health study, nearly 30,000 healthy American women, where 77% of all future heart attacks and strokes occurred among women with cholesterol levels, LDL levels, less than 160. And in fact, 45% of all future vascular events occurred among women with LDL levels less than 130. So both the treatment and the targets for LDL reduction really miss more than half of all future vascular events. In contrast, what we also found was that screening for the inflammatory process, in general, CRP in particular, was an extremely potent way of predicting future vascular events. We found that for the endpoint of myocardial infarction, the endpoint of stroke, total cardiovascular events, cardiovascular death, that CRP levels outperformed LDL cholesterol levels in every category: relative risks, population attributable risks, and the absolute risk of having an event. But the most interesting observation in the new data is that the highest risk group, not surprisingly, are those with both inflammation and high cholesterol levels, and the lowest risk group are those who have neither. But it turned out that the 25% of this healthy American population who had a high CRP and a low LDL was actually at substantially higher risk than those with a high LDL and a low CRP. But remember, the latter are within current guidelines for therapy, and the former are not. So we need to really change how we think about this disease, because we now understand that the inflammatory process is at least as important as the cholesterol levels, and some of us think perhaps even more important. The relevance of all of this gets at the fact that the CRP is adding to the Framingham risk score, it's adding to LDL cholesterol, and in fact it's telling us in large part who has the metabolic syndrome. In a very similar analysis, we've been able to show that a CRP level greater than or less than 3 is almost as predictive of outcomes as is measuring the entire metabolic syndrome. What this is telling us is fundamentally how important inflammation is, and we must now move the inflammatory hypothesis out of the laboratory and into clinical practice, because once that's achieved, our broader goal of identifying high-risk patients will be much, much closer to a reality.